Here we are talking about pharmacology of insulin and secretagogues. Our objectives for both sessions combined. Little Titus is trying to give us a hint that right now in this session, we're going to focus on blood glucose levels, interpretation of them to appropriately adjust medications in the context of Shomoji versus Dawn phenomenon. Don't worry, we'll get there. We'll talk about it. Just in case, a little bit of insulin dosing terminology. I wanted to point out covered sliding scale correction dose used short or rapid acting insulin to bring an already elevated glucose down, as opposed to prandial dosing, which is also known as mealtime dosing. We're actually using a rapid or short acting insulin at the beginning of a meal to prevent a postprandial rise. Sometimes, especially type 1 diabetics will perform carbohydrate counting, where they figure out how many carbs they're going to ingest, and they adjust their insulin based upon their ingestion of carbs. Insulin is dosed in units. 1 unit is 1 molecule of insulin. And we have 3 concentrations available on the market. U100 has 100 units per mil, U300, U500. So here's a question. Who do you think uses U500 insulin, type 1 diabetics or type 2? If you said type 2, you're right, because type 2 diabetes, as I'm sure you're aware, and as we'll talk briefly about, is caused by insulin resistance. And if you're resistant to insulin, you require a higher dose. Here's our list of drugs to know. So in the first session, we're focusing on the drugs on the left, drugs that increase insulin. Little Christmas Finn here. Finn is my buddy. I had fun with him at Med Wars. Anyway, Finn wants you to know that if we increase insulin in the body, we have risk of hypoglycemia and risk of weight gain. This risk of weight gain means that sometimes fashion conscious, body habitus conscious adolescents skip their insulin to try to lose weight. Finn also wants you to think about that. We're going to talk about some other drugs in these 2 sessions. Drugs to manage hypoglycemia, drugs that mask hypoglycemia, remember our beta blockers, drugs and beta islet cells, and then drugs that cause hyperglycemia in the column on the right, focusing on glucocorticosteroids. This is FYI. This is telling you what I'm going to tell you. And I'm hoping that by the end of these 2 sessions, you will understand the pharmacology, how the class of drugs works so well that you won't ever need a chart like this. You'll be able to say, oh, glyburide, that's a secretagogue. It increases insulin in the body, which means it has a risk of hypoglycemia, a risk of weight gain. We're also only going to look at weight loss medications in the context of how they're used in type 2 diabetes. We're also not really going to be talking about all the things you need to think about when you're managing a diabetic patient. Our focus is on glucose and metabolism. You always need to treat the patient, not just the number. Some important concepts. We already said type 1 diabetes, autoimmune destruction of the pancreas, no insulin. Type 2 diabetes is what we actually said already. Metabolic dysregulation, insulin resistance. Really exciting stuff for type 1 diabetes going on. Teplizumab TZIELD can delay the onset of type 1 diabetes. It's an immune suppressant. It can delay type 1 diabetes by about 2 years. On the other side of that coin, we have our immune checkpoint inhibitors, things like pembrolizumab, which is Keytruda, or ipilimumab, which is Yervoy, that are used to prevent turning off the immune system. They can actually cause autoimmune destruction of the pancreas. Bummer. Really exciting news, late 2023, early 2024. If we inhibit histone methylation by EZ2H, for example, the drug tezometostat, which is used for some certain epithelial cancers, can actually increase pancreatic duct cell transformation into insulin secreting cells. So kind of exciting for type 1 patients. I want to point out that in hyperglycemia, insulin deficiency, glucose is an effective osmole. When we have excesses of glucose in circulation in the bloodstream, it's going to cause water to leave the intracellular compartment to dilute the glucose. But at the same time, the sodium is going to get diluted too. So I provided for you here just FYI how we correct serum sodium concentrations in a patient who's hyperglycemic. I also want to point out that in hyperglycemia, we saturate the SGLT2 transporters in the proximal tubule of the kidney. This is going to lead to osmotic diuresis. We're going to lose water, and we're also going to lose potassium, as the body's exchanging sodium for potassium. So in diabetic ketoacidosis, our serum potassium levels may be elevated, but it may actually be that the patient is in a total body state of potassium loss, right? They're low body stores of potassium. Insulin secretagogues through increased insulin secretion, risk of hypoglycemia, risk of weight gain. But also remember that insulin causes potassium to shift intracellularly. At the level of the kidney, insulin is going to increase sodium and water retention. Pointing out also that rapid-acting insulin, since we're usually dosing them around a meal or adjusting an already high blood glucose, which is really not the preferred thing to do, but that's another story. Slightly lower risk of hypoglycemia simply because we're adjusting, we're making sure that the insulin is matching a carb, matching a blood glucose level. I also want to point out that hyperinsulinemia causes insulin resistance. Adipocytes, fat cells, secrete cytokines. The inflammation causes insulin resistance, which can create a vicious cycle. Not all patients with obesity become diabetic, and not all type 2 diabetics have obesity. Let's look briefly at a review of counter-regulatory controls. So we have a 54-year-old male who reports for routine follow-up. His medical history is significant for type 2, managed with metformin and pioglitazone, hypothyroidism treated with levothyroxine, asthma managed with budesonide and albuterol, and recent Hodgkin lymphoma treated with pembrolizumab Keytruda. He started burst therapy with oral methylprednisolone last week to manage an acute exacerbation of asthma. Labs include elevated fasting glucose, his A1C at target at 5.9%, elevated C-peptide at 3.2 nanomoles per liter, and normal TSH. What is most likely causing his elevated blood glucose? Ooh, don't you love questions like this? Albuterol, glucocorticoids, levothyroxine, metformin, hypothyroidism, or pembrolizumab. Well, let's look at his labs. Okay, he's got an elevated blood glucose. We already said that. But his A1C is pretty normal. So maybe you might be thinking, okay, this is not really a chronic state. Maybe this is something relatively new. Also, we see elevated C-peptide. So what is C-peptide? Well, if you remember, C-peptide is secreted every time a molecule of insulin is secreted. So this means his pancreas is secreting a lot of insulin. His thyroid, his TSH, normal. So, you're probably not thinking hypothyroidism, right? So we can scratch out E right there. The fact that he's secreting insulin means he has a pancreas, so we can scratch out F. It's probably not pembrolizumab. I'll tell you right now, we'll talk about metformin induced Shomoji rebound. Shomoji is a response to hypoglycemia. Metformin does not increase insulin in the body, no risk of hypoglycemia. Levothyroxine induced insulin degradation. Well, yes, to be fair, thyroid hormone increases metabolism, does increase insulin degradation, but he's been on levothyroxine for a while, probably doesn't say it was newly added. And as we said, we're thinking of something kind of acute. Glucocorticoid-induced insulin secretion or albuterol-induced inhibition of insulin secretion. Well, we already see that he's got elevated insulin from elevated C-peptide, so we know that this is glucocorticoid-induced insulin secretion. Excuse me, insulin resistance. And look, there's my friend Finn again. This is Summer Finn telling you to focus on glucocorticoid-induced insulin resistance. And if you just want to remember briefly, insulin inhibits glucose production by the liver, stimulates glucose use by muscle and adipose tissue, but cortisol and growth hormone are going to stimulate hepatic gluconeogenesis and inhibit glucose use. Our catecholamines and glucagon also are going to stimulate hepatic gluconeogenesis. So cortisol is kind of the opposite of insulin. Look, little biscuit. So biscuits have lots of carbs. Carbs increase blood glucose. So do steroids. So at the level of the brain, we're going to get hyperphagia and weight gain. This, we also get central insulin resistance. At the level of the liver, we're going to see increased gluconeogenesis, increased lipogenesis, increase in circulating fats, excuse me. That increase in free fatty acids also causes insulin resistance. And then at the level of the skeletal muscle, we see decreased sensitization to insulin, which of course is insulin resistance. So here's another question. Glucagon are GS protein coupled receptors. They're found extensively in the liver, in the heart, and less so in the smooth muscle. What effect do you expect from GS coupled receptor activation in the liver, in the myocardium, and in the GI tract? Well, in the liver, we get gluconeogenesis. Remember, glucagon is released when glucose is gone. We want to, glucagon increases blood glucose. Myocardium, GS protein coupled receptor, like the beta-1 receptor, GS protein coupled, positive inotrope, positive dromotrope, positive lucitrope, positive chronotrope. We can actually use glucagon to treat beta blocker overdose. It's not activating the beta-1 receptors in the heart, but because they're GS protein coupled receptors in the heart, they do the same thing. High dose glucagon can be used to treat beta blocker toxicity. In the GI tract, relaxation. Sometimes in diagnostic imaging, we'll give doses of glucagon to relax the GI tract to get a better image. So again, glucagon receptors are found in many tissues that also express beta adrenergic receptors. And in general, if we increase cyclic AMP at the beta-1 in the heart, just like the beta-1 receptor, we get increased force and rate, etc. In smooth muscle, we get relaxation. So here's another question. Which enzyme is ultimately activated by glucagon via phosphorylation, excuse me, to increase glycogenolysis? Is it glycogen synthase kinase 3 beta, glycogen synthase, or glycogen phosphorylase? Glycogen phosphorylase is activated by phosphorylation. In the graphic, the gray shape indicates active, the orange octagon or stop sign is inactive, and the blue P is phosphorylation. In the fasting state, glycogen synthase and glycogen phosphorylase are both phosphorylated, and this is going to activate the phosphorylase to promote glycogenolysis and inhibition of glycogen synthase to prevent glycogenesis. Insulin, via the inositol triphosphate pathway, inhibits GSK3 beta, which leads to activation of glycogen synthase. We're going to synthesize a glycogen in the presence when glycogen synthase, is activated. GSK3 is implicated in the pathogenesis of insulin resistance, with GS3K levels being elevated in the skeletal muscle biopsy of those with type 2 diabetes. Glycogen synthase kinase 3 beta is also a powerful regulator and promoter of inflammation. And maybe remember that interferon gamma suppresses interleukin 10 production by increasing GSK3 activity. Oops, excuse me. So if you look at the little chart here, we're looking at things that regulate either in the liver or the muscle. So things that regulate glycogen synthase in the liver, insulin turns it on, glucose turns it on, glucagon and epinephrine turn it off. Insulin promotes glycogen synthase in the skeletal muscle, epinephrine inhibits. Glycogen phosphorylase, whose job is to turn glycogen into glucose 6-phosphate, stimulated by epinephrine and glucagon, inhibited by insulin, activated by adenosine monophosphate kinase, metformin, and also epinephrine, and inhibited by ATP and insulin. Just a quick review. I'm not here to teach you biochem, but trying to get some of this tied together for you maybe. Quick review, regulation of insulin secretion. GLUT2 transporters are constitutively expressed, and they facilitate entry of glucose into the beta islet cell. Glucose metabolism increases the ATP to ADP ratio and also increases NADH to NAD ratios. The increased ATP to ADP slams shut that outward flowing potassium channel, K-ATP channel, also known as the sulfonylurea receptor. High voltage activated calcium channels then open, which leads to exocytosis of insulin and C-peptide. Beta-2 agonists, acetylcholine and cholecystokinin are going to all increase insulin release. GIP and GLP-1 are going to cause increased sensitivity for insulin exocytosis when carbs enter the GI tract. This is a feed-forward mechanism. Things that inhibit insulin release include galanin, alpha-2 agonists, somatostatin. Phenytoin, colchicine, and vinblastine may also inhibit insulin release to some degree. So question, which pathway prevents hypoglycemia during exercise in healthy non-diabetics? Celiac nerve activation, vagal activation, or neurohumoral activation? And the answer is activation of the celiac nerve. It's going to release norepinephrine. We have no beta-2 activity from norepi, remember, so we get alpha-2 activation, which is going to inhibit insulin release. So I kind of wanted to tie this to why exogenous insulin and secretagogues are going to have an additive increased risk of hypoglycemia when combined with exercise, because it's not under homeostatic control, right? When we exercise, otherwise, normal homeostasis prevents insulin release while we exercise. But if we're increasing insulin in the body by poking at the body with a drug, we don't have that innate protection. So let's look briefly at drug-induced hyperglycemia. The different colored boxes here indicate drugs that can cause hyperglycemia by more than one mechanism. I don't really want you to memorize this, but do notice that the glucocorticosteroids are here, right? If you care from the most current, the standards of care in diabetes published January 2024 by the American Diabetes Association are saying, like, let's watch these patients for hyperglycemia, even if they're not diabetic, particularly, pre-diabetics, or even actually full diabetic patients with full diagnosis of diabetes, excuse me. But notice what's in red: glucocorticosteroids. Statins can cause hyperglycemia, thiazide, some antiretrovirals, second-generation antipsychotics. And since you're in behavioral med right now, also, I'm pretty sure that you might get tested on that. The fact that atypical antipsychotics can actually cause full-blown diabetes mellitus, type 2 diabetes. Review of insulin. So here we see, this is just kind of like my title slide, but remember there's the C-peptide and there's the 2 disulfide bridges between the A chain and the B chain of insulin. When this proinsulin molecule is secreted, we snip the A chain and the B chain from the C-peptide, releasing a molecule of insulin and a molecule of C-peptide. There are 2 main pathways of importance that we think about by the insulin signal. One is a mitogenic pathway that's activated by RAS and MAP kinases to increase cell growth. The other is a metabolic pathway via the IP3 kinase activation of AKT, which is also known as protein kinase B, which mTOR activation of protein synthesis. And remember that our calcineurin inhibitors are going to cause hyperglycemia, maybe through disruption of this pathway. We're going to see inhibition of glycogen synthase kinase 3 beta that we already talked about. And we're going to increase expression of GLUT4 transporters on skeletal muscle to facilitate glucose uptake by skeletal muscle. The mitogenic pathway doesn't develop resistance to insulin as readily does the metabolic pathway. What morbidities may be associated with hyperinsulinemia due to increased signaling in the mitogenic pathway? Well, pseudoacromegaly, soft tissue and bone changes without elevations in GH or IGF-1. Atherosclerosis, in part we get changes in the intima that may be insulin driven, certain cancers, and also not, chicken or egg kind of thing, but increased testosterone synthesis may be due in part to the insulin resistance. So let's look at insulin and selected organs. 3 primary insulin sensitive organs, but there's others that we'll talk about. We're mostly going to focus on adipocytes, liver, and skeletal muscle. The brain and the kidney are also important. Don't freak out about the little pathways. This is to remind you that now might be a good time to just kind of look at your metabolic biochemistry a little bit. But the bottom line, in the liver, when we add insulin, we get glycogenesis, we get glycolysis and carb utilization, we get fat synthesis and storage, and we get increased protein synthesis. In the adipocytes, we see essentially fat storage. We see increased release of inflammatory cytokines, platelet activator inhibitor 1, angiotensinogen, etc. And so here we have our little maverick and our little fin together. wanting to remind us, why do appearance-conscious adolescents skip their insulin? Because they want to lose weight. At the level of the skeletal muscle, I wanted to point out and remind you that insulin causes glucose and potassium to shift into skeletal muscle. So we can use insulin to transiently treat hyperkalemia by moving it from the bloodstream into the skeletal muscle. In patients who are euglycemic and hyperkalemic, we're going to give insulin plus glucose. But if we have a patient who's hyperkalemic and hyperglycemic, we give just the insulin because it'll fix both together. Insulin in the brain. In the healthy brain, we see insulin causing satiety associated with our recognition of food intake. But we see that altered insulin action in the brain can lead to increased food intake, depression, anxiety, also some cognitive changes. So I have the pathway outlined here for you because I know Dr. DeFranco is talking about obesity. I just really kind of like this graphic. I'm kind of a graphic person. I like them. In the kidney, I wanted to point out that we get edema from insulin because it increases expression of the ENaC in the collecting duct cells. I wanted to also point out that thiazolidinediones, things like pioglitazone, really enhance the sensitivity of these cells to insulin. So pioglitazone and other thiazolidinediones can cause significant edema, particularly in those who already have heart failure. So here's an overview of some important insulin effects. We get decreased glucagon release, increased GLUT4 expression, increased glycogen synthesis and storage, weight gain, increased protein synthesis, increased ENaC in the kidney, which can increase sodium and therefore water resorption, shifting of potassium into the cell. We can get activation of carboxypeptidase to release alpha melanocyte stimulating hormone from POMC, which is how actually insulin causes its satiety effect. And if exogenous insulin is injected in euglycemic patients, we might get hypoglycemia. Actually, probably will get hypoglycemia. Let's move on to insulin as a drug. We have a 52-year-old female presenting with dizziness, palpitations, and muscle weakness. Her pulse is 75 and her blood pressure is 110/70. Lead 2 over ECG is seen at the right. Insulin and glucose are administered. How did insulin work to address the underlying cause of her symptoms? What type of insulin did she likely receive? So insulin is going to increase skeletal muscle uptake of potassium. It's going to increase those GLUT4 transporters, which increases glucose and potassium uptake by skeletal muscle. Which insulin? So we want something fast. We had this symptomatic hyperkalemic patient, and we can see by the T waves on her ECG, peaked T waves. Remember, I always try to remember that the waves go in the direction of the potassium. So T waves, peak T waves in hyper, U waves in hypo. And we want something rapid, so regular insulin can be given intravenously. Neither glargine nor NPH can be given IV. Both have a slow onset. Our insulin analogs like Aspart, Lispro, glulisine, really no pharmacokinetic advantage to give them IV. They can be given intravenously, but we generally don't. Oh, look, there's little Daisy. One of our objectives was, I think, comparing insulin as a drug to endogenous insulin. Really, your biggie is going to be C-peptide. Every time our pancreas secretes insulin, it secretes a molecule of C-peptide. Half-life of endogenous insulin about 5 to 10 minutes. Most of the insulin that's secreted by the beta islet cells is immediately taken up by the liver, and therefore it's cleared largely by the liver. Exogenously, we don't have that C-peptide. Half-life depends on the insulin, lots of different factors. We can actually increase the rate of absorption by rubbing the site if we give sub-Q insulin. So you want to be cognizant of how you teach your patients to inject insulin. That's way beyond the scope of this lecture, though. And then since we inject IV sub-Q, we are bypassing hepatic first-pass metabolism. Most of our injected insulin is cleared by the kidney. If you care, differences in insulin molecularly. NPH stands for neutralized protamine Hendorn. Protamine, remember, is the specific antidote for heparin. However, it is made from salmon sperm, and many patients become sensitized to it, so they can have a protamine allergy. Regular insulin is sometimes known as crystalline zinc insulin. Just like insulin in the beta islet cell of our pancreas, it forms a hexamer with zinc. When we inject it subcutaneously, it slowly, well, I mean, not really slowly, but it dissociates from the zinc over like probably about 30 minutes. Whereas our really, as we'll see, our ultra short acting onset much more rapid. Sorry, I'm kind of stuttering here. Insulin analog relative kinetics. So our very rapid insulins are aspart, lisproglulisine, onset in 10 to 30 minutes. These types of insulin are our preprandial doses, our correction doses, the kind that we put in insulin pumps. Regular, as I said, the crystalline zinc, onset about a half an hour. It's used kind of the same as rapid. We have NPH, or sometimes known as N insulin, intermediate insulin. So if you're looking at the graphic on the left, we see the black peak, rapid peak, aspart, lisproglulisine, regular insulin, followed by NPH next. Then we have our peakless, also known as basal insulins, detamere, glargine, degludec, excuse me. Onset is 1 to 2 hours. The duration is going to vary with the product. And these are usually used as basal insulin. We'll talk a little bit about insulin secretion patterns. I made the little graphic, the little railroad track there at the bottom, just to give you a visual to think about the rapidity of onset, which is, kind of important, I think, for short-term goals. I mean, not exquisitely short-term goals from my perspective, but I think level one, step one, you probably need to know the relative onset of insulins. For your information, Novo Nordisk is coming out with a new insulin that's not yet approved. Icodec for type 2 is going to be a once-a-week injection. So insulin secretion patterns. We have a basal level of insulin secretion. It's never zero. And then we see a blue dotted line in the graphic to the left that is this basal insulin. And then we have, in this schematic of injected insulin, the orange peaks marking where the injected insulin would be. The purple area is the endogenous insulin secretion, right? So this is looking at giving this is basal bolus dosing, where we're giving basal insulin probably at bedtime the night before. And then with each meal, we're giving a dose of a shorter rapid acting insulin. And so this is multiple daily injections, also known as basal bolus. Please excuse me. On the right, we're looking at split mixed insulin, NPH, the green line, mixed already in solution with a shorter rapid insulin, the orange line, administered twice daily, and we're getting 4 insulin peaks. So we get 2 peaks from the NPH and 2 peaks from the rapid acting insulin. This is known as split mixed insulin dosing, and the patient has to eat the same amount of carbohydrate at the same time every day, or they risk hypoglycemia. If you care in type 1 diabetes, here's a summary of different insulin injection regimens way beyond your needs at this time. As I mentioned earlier, teplizumab Tzield is a new drug to delay progression of stage 2 to stage 3 type 1 diabetes. It is a anti-CD3 antibody. So is that going to be in type 1 diabetes anyway? Is that going to be targeting CD4 or CD8? Because notice our CD3 is on both CD4 and CD8 cells. Well, and our beta islet cells of the pancreas aren't professional antigen presenting cells, so they have type 1 HLA. Therefore, it's going to be our cytotoxic CD8 T cells that we're really targeting with this teplizumab. So the question here is, which effect is unlikely? Are we going to see hyperresponsiveness to live vaccines, infusion reactions, infections, lymphopenia? Which one of those is probably not going to happen? Well, the answer is we're going to see a diminished response to live vaccines. And again, with immunosuppressants, we want to avoid live vaccines. There's another case. We have a 64-year-old female who's using split mix Novolog 7525. So each mil of this insulin contains 75 units of NPH and 25 units of aspart. Her morning glucose is consistently elevated. What are you going to do about it? Do we want to add a basal insulin? Do we want to add metformin? Do we want to check her blood glucose at 0300? Do we want to decrease her evening insulin, or do you want to increase her evening insulin? Well, here's where we're getting to, as our friends Finley and Bandit would say, Dawn phenomena and Shomaji effect. So what we want to do in a patient who's got early morning elevations of blood glucose, we want to have them check the blood glucose at 0300 to 0500, right? 3 a.m. to 5 a.m. So if we look at this graphic on the right, the red line, the upper line is dawn phenomenon. So when we, in our normal circadian rhythm, we secrete growth hormone, we secrete cortisol early in the morning. And if you remember that counter-regulatory slide, both growth hormone and cortisol cause insulin resistance. So this is the most common cause of elevated blood glucose, elevated fasting blood glucose, especially in type 2 diabetics. It's just normal circadian rhythm, right? In patients on insulin, however, especially type 1 diabetics, it's actually much more common. If we have a nadir, a really low blood glucose, about 0300 to 0500, we get an overcorrection. We get excess hepatic gluconeogenesis, leading to a rebound increase in blood glucose in the morning. So, dawn phenomenon, natural occurrence, normal circadian rhythm, and dawn phenomenon. If we find that the 0300 blood glucose is normal to elevated, we're going to increase the dose of the evening insulin. On the other hand, with Shomaji effect, if we have an early morning low blood glucose, then we need to decrease the dose of the insulin that caused it. This is an important concept. Finley and Bandit both want you to know that you need to know this. It was an objective specifically that was in red, if you remember Titus telling you that. Just in, will be on the test. 32-year-old moderately obese male presents with blurred vision, frequent thirst and urination, and unexplained loss of 10 pounds over the past several weeks. Blood glucose is 650. His C-peptide is 50. He's admitted to hospital for treatment. Which insulin regimen do we want for his initial treatment? IV glargine, IV crystalline zinc, sub-Q NPH, or subcutaneous insulin detamir? And then at discharge, which option will be most appropriately used to most appropriately address his postprandial blood glucose elevation? Exenatide, metformin, repaglinide, sitagliptin, sub-Q exenatide, sub-Q insulin aspart, or sub-Q insulin glargine. Oh my gosh. So insulin, most appropriate for initial treatment, IV. This is an emergency, right? He's got blurred vision, frequent thirst, urination, really high blood glucose. Okay, so we want to give him insulin to correct the underlying metabolic disorder. We're really not, targeting the blood glucose per se, but fixing all the things that are kind of broken. Severe presentation, we need IV insulin. At discharge, what are we going to do? Well, if you notice, his C-peptide was way low. Normally, it's going to be above 200. His was only 50. That means that he's not got insulin. So he needs some kind of insulin. And the graph at the left is depicting that basal bolus, glargine being green, and a rapid-acting insulin for bolus being orange for postprandial increases. So I guess the question was acting, which would best address his postprandial increase? So the basal insulin, in this case, if it was glargine, would just be that basal. It wouldn't really be impacting the carbs he's putting in his mouth. It's to kind of control that early morning blood glucose. So postprandial glucose would be best controlled with a rapid-acting insulin subcutaneously, like Aspart, Lispro, glulicine, or even crystalline zinc, also known as regular. Sorry if I said that confusingly. Here's what continuous glucose monitoring looks like. This is from a Medtronic pump. So basically, we're seeing all the way at the left, 12 a.m. midnight to, it looks like it's 8 p.m. on this graphic. So this is from a patient who's using an insulin pump. And I'm asking here at the 0600 blood glucose peaks on 316 and 314, where the blue arrow is, are these Shomaji effect or dawn phenomenon? And what are we going to do? We're going to increase basal rate, decrease basal rate, increase bolus rate, or decrease the bolus rate. Okay, so look at that overnight level. We got hypoglycemic on both of those days. So this is Shomoji effect. The low blood glucose at 300 is going to cause an excessive hepatic glucose release. This is why this person woke up with an elevated blood glucose. So little Kyla and Biscuit here, we want to decrease the basal rate. This patient had a really low blood glucose at 0300, so we want to prevent that low blood glucose by lowering the insulin dose that caused it. If the 0300 glucose was 130 milligrams per deciliter, what would you do about that? In that case, we're going to want to increase the dose, the basal rate that caused it. Because if the 0300 glucose is 130, that would be the dawn effect. And we would want to prevent waking up with an elevated blood glucose by increasing the dose, the bedtime dose. So the acute complication of insulin secretagogues, hypoglycemia. Lots of causes, could be behavioral issues, problems with counter-regulatory mechanisms, lack of recognition of hypoglycemia, such as beta blockers. And I want you to think about this. Low blood glucose kills your brain quickly. You can live for a long time with a high blood glucose. So the bottom line is, say you're camping, you have no way, you're hiking, you have no way of knowing, you have a patient that is a known diabetic and they're obtunded, yada, yada, yada. Probably if you had no way of differentiating the two, you want to give something that's going to bring the glucose up, because hypoglycemia kills you quickly. I mean, symptomatically, you should be able to discern it, but I'm just saying hypoglycemia kills you quickly. Symptoms related to the level of hypoglycemia, so less than 60, we're going to see nausea, hunger, some parasympathetic effects. We might also see some sympathetic effects, tachycardia, palpitation, sweating, tremor. If it's less than 50, now we're starting to see CNS effects, blurred vision. Less than 30, probably loss of consciousness. I also want to point out that sometimes patients who have lived for a long time with elevated blood glucose will develop symptoms of hypoglycemia even when their blood glucose is high. So they might come down from, say, a blood glucose of we'll just say 200, and they drop down to 160. They may experience symptoms of hypoglycemia, even though they're still hypoglycemic. What do we do about hypoglycemia? Well, we treat all symptoms and or blood glucose levels less than 70 milligrams per deciliter. 15 grams of quick carb. So a couple of glucose tablets, 3 to 8 lifesavers, some sweetened juice, soda pop that's sweetened, cake icing in a tube is a quick option. We're going to give that quick carb. We're going to reassess them in 15 minutes. We'll repeat the carb if needed. And we have to think about things that delay gastric emptying, though, and we'll come to that in the next session. We're going to add an additional snack if the next meal is more than an hour away. If the patient is unconscious, we want to give them glucagon or intravenous glucose. Patients, remember, might have blunted hypoglycemic awareness if they're on a beta blocker. And just if you care, some people have finger stick blood glucose monitors. In hypoglycemia, those finger sticks probably aren't accurate. So this is a chart from the ADA 2024 guidelines, talking about the classification of hypoglycemia. And to quote the American Diabetes Association, all individuals treated with insulin or those at high risk of hypoglycemia should be prescribed glucagon. In other words, secretagogues, insulin, probably want to give them glucagon also. For your information, risk of hypoglycemia from the ADA guidelines states, individuals treated with insulin, sulfonylureas, or meglitinides. In other words, insulin or secretagogues cause a risk of hypoglycemia and weight gain. And I also wanted to point out from the ADA guidelines, impaired hypoglycemic awareness, beta blockers, right? So some other meds to treat hypoglycemia, we already talked about glucagon, and there's also an analog dasiglucagon, which is a glucagon receptor agonist, that's intranasal. But we also have diazoxide proglycem, which is actually a potassium KATP sulfonylurea receptor, if you want to call it that, potassium channel opener. It's going to cause hyperpolarization of the beta islet cell to prevent insulin release. This drug is widely used for sulfonylurea overdose insulinomas, as is octreotide. which is pretty much an analog of sandostatin, which I call, I'm sorry, octreotide is the generic name for sandostatin, which is an analog of somatostatin, too many statins in there, right? That also is kind of like the putter hour. It's going to prevent insulin release. Both diazoxide and octreotide can be used for sulfonylurea overdose, and they'll work by preventing further insulin release. And we'll get to that in the next section. I'm sorry, kind of thinking ahead. Moving on to our secretagogues. First generation, no longer used: chlorpropamide, tolbutamide, tolazamide. Second generations, notice they all start with gly or gly: glipizide, glyburide, glimepiride. We also have our meglitinides, sometimes called the glinides, repaglinide, and nateglinide. So what is the site of action of glyburide? Is it one? This is a beta islet cell. Is glyburide's action 1, 2, 3, or 4? And also, which enzyme is responsible for trapping glucose in this cell? Is it glucokinase, hexokinase, phosphofructokinase, or fructose 1,6 biphosphatase? So the site of action of glyburide is 2, that outward flowing KATP, that ATP sensitive potassium channel, also known as the sulfonylurea receptor. Glyburide will plug that hole, if you will, causing potassium to accumulate within the cell, causing the beta islet cell to depolarize, causing exocytosis of insulin and C-peptide. Which enzyme is responsible for trapping glucose in the cell? Well, glucokinase. It's also known as a glucose sensor. It adds that phosphate that's going to trap glucose. And it's also going to create a concentration gradient because glucose 6-phosphate is not glucose, right? So we get ion trapping and an increased concentration gradient. Oh, look, there's little Mila. So secretagogues, sulfonylureas and glinides are both 2 classes of secretagogue. They both block the KATP channel, which is going to increase insulin and C-peptide release, right? So sulfonylureas, the difference between the 2 classes is just pharmacokinetic. The sulfonylureas, slow onset, long duration. I like to call the glinides insulin on demand because they're taken at the beginning of a meal. They rapidly block that outward flowing potassium channel, releasing insulin for a brief period of time before they stop working. So the patient takes these with a first bite of a meal. If they don't eat the meal, they don't take the drug, right? Also in this graphic, I have an arrow here looking at glucose-dependent insulin release. So notice that this is the incretin receptor. It's a G-protein coupled receptor, I think. And when our GIP, glucose insulinotropic peptide, or GLP-1, glucagon-like peptide 1, bind to that incretin receptor on the beta islet cell of the pancreas, it sensitizes that KATP channel to ATP. So it kind of pre-warns the beta islet cell of the pancreas that glucose is coming. So we get an increased amount of insulin release in response to glucose in the GI tract. Because GIP and GLP-1, if you remember, are secreted by the L-type cells in the GI tract. And we'll talk again about that in the next session. Aren't you glad? So what do you think? Secretagogues, weight gain, yes or no? Well, they increase insulin release. So yes. Hypoglycemia? Yes. Contribute to hyperinsulinemia? Yes. Increase C-peptide? Yes. And again, to reiterate, glinides, insulin on demand, often used when the patient has irregular meal times. Neither of these 2 classes are first line because remember what we said. Number 1, insulin, hyperinsulinemia causes insulin resistance. These drugs increase insulin. So they're going to cause insulin resistance, weight gain, and risk of hypoglycemia. The risk of hypoglycemia is less with the glinides since if you're not going to eat the meal, you don't take the drug, right? They're shorter acting, so slightly lower risk. For your information, some weird things about chlorpropamide diabetes may have a disulfiram-like effect with ethanol. So I made this memory tool for disulfiram drugs. Disulfiram can cause great malaise. D for disulfiram, C for chlorpropamide, C for cefotetan, some other cephalosporins that have an NMTT side chain, G for griseofulvin, which is an antifungal, and M for metronidazole. Also, chlorpropamide can cause SIADH. Now we have a question. 76-year-old male presenting to the emergency department with weakness, dizziness, and confusion. Med history significant for heart failure, hypertension, and CKD with type 2 diabetes. Meds include glyburide, metformin, metoprolol, and lisinopril. At presentation, his blood glucose was 22 milligrams per deciliter. Yes. He had 6 50 milliamps of D50, extra 50%. His blood glucose increased only to 60. What would most appropriately treat his hypoglycemia? Epi, oral sucrose, oral dextrose, octreotide, or phentolamine? Answer is octreotide. It's going to block insulin release, including GLP-1 to GIP-induced glucose-dependent insulin release in response to the oral glucose load. So he's on glyburide. Glyburide slams that potassium channel shut, causing a continuous insulin release. If you add glucose, you get more insulin release, right? So theoretically, at least when we have overdoses of things like glyburide, we want to use either glucagon, well, we can use glucagon, but we actually prefer to use octreotide or diazoxide. One of the objectives, look, Jack is saying meow bot here, insulin and secretagogue comparison. Similarities, they both increase insulin in the body. The effects on metabolism are the same. They both can cause hypoglycemia. They both can cause weight gain. Both can be used in type 2 diabetes. But remember, insulin is a must in type 1. The difference is secretagogues are only effective in type 2. They're oral agents, not IV or inhaled. We have to think about their side effect profiles. So potentially a sulfonamide cross-sensitivity. I think in the ComBank questions, there was a question about sulfonamide cross-sensitivity. It's actually kind of controversial, but don't worry about that, right? If you see it on USMLE or Comlex, it'll probably be, that they're affirming that the cross-sensitivity does indeed exist. Chlorpropamide has weird side effects, remember. When we give a secretagogue, we're going to increase insulin secretion. Therefore, we increase C-peptide secretion. And in overdose, there is at least a theoretical concern that carbs can increase the amount of insulin released. Now that that's all said, if you have any questions, I'm in DCOM230. You know my email address. And I hope you have a lovely day.